Dr. Sri Rao. He's a resident pediatric cardiologist here with us.
PCY 30 or 24, something like that.
Perfect. Okay, so I guess we'll just get right into it. Okay, so our first paper that we're going to go over was the sildenafil prevents rebound pulmonary hypertension with withdrawal of nitric oxide in children. So I'd originally kind of chosen this just after my rotation up in NICU, and I had and as well as in PICU, we had a couple kids with pulmonary hypertension, and we just approached them differently with adding sildenafil to the regimen, and it turns out we had, there were good reasons for it, and that there wasn't necessarily standardization of weaning nitric oxide while we were in the NICU, and so I thought that was just kind of something I wanted to look into, because one of our little guys had a little bit of rebound that I wasn't, sure why it was happening and what we could have done about it. So this one was out of the Royal Children's Hospital in Melbourne, Australia. It was a prospective randomized placebo-controlled study. So they were planning on doing it beforehand with the primary outcome of measuring the development of rebound pulmonary hypertension with the addition of sildenafil. So kind of in the introduction, they talk about inhaled nitric oxide and the effects on the pulmonary vasculature, and obviously the main course of vasodilation with affecting guanylyl cyclase activity, and with the intent of increasing cyclic GMP, kind of not systemically, but locally in the pulmonary vasculature. And the intent is also to not drop peripheral vasculature like hypertension or hypotension effects. And so they wanted to, they have a good amount of patients that were post-op from cardiac surgery, and then a few others that had some pneumonias and what have you. And there was already some mention that there is no link to increased survival, that it's mostly temporary based, the effect of nitric oxide. So they've been consistently seeing the complication of rebound pulmonary hypertension with withdrawal, and they're thinking that this has to do with some of the downregulation of the enzymes. And so they are starting to see, per weaning protocols, at around 500 parts per million of nitric oxide, they can start to measure increased right atrial pressures, and which leads to difficult ventilation, more severe hypoxia, and cardiovascular instability. And so typically with that rebound, they do have to reinstate the nitric oxide, which starts to put these patients at higher risks of things like methemoglobinemia. And so their proposed mechanism is that since they're giving exogenous nitric oxide which has the effect of decreasing nitric oxide synthase and guanylyl synthase activity, that if they start to replete pharmaceutically, repleting cyclic cGMP, that they might get over the hump of rebound. So that was kind of their intent. And so the sildenafil has, as a PDE5 inhibitor, has a lot of worthwhile studies in the pediatric population. So the inclusion criteria was children who were mechanically vented, nitric oxide at least 10 parts per million was being given for a minimum of 12 hours with an average age of 6 months, and their N was 30 total patients. Exclusion criteria was any previous failures from weaning, any current uses of IV nitrovasodilators, liver failure, inspired O2 fraction higher than 0.6, congenital heart disease with obstructed pulmonary or systemic, I can't remember what that one was. And and no other, and they don't, if they didn't have any measurable PA pressure, RV pressures. And so for this study, there were 14 controls and 15 total sildenafil patients, as one control patient did pass away during the study. For randomization, the provider and the patient were both blinded to the study. All patients received either placebo or a drug with an average concentration of 0.4 milligrams per kilogram of sildenafil or sugar pill. in 1 to 5 milligram capsules per OG. So let's see. Okay, and so the original indication for the for all these patients, the original indication for the nitric oxide, just to kind of standardize the patients, was early post-surgical after cardiac surgery for several corrections, and that was 20 of the patients. 2 of the patients were ex-premature children with chronic lung disease. There were chronic lung disease with pneumonia, which is 3 of the patients, and 1 of the patients had previous cardiac abnormalities and was there for a sepsis workup, and 3 were there for pulmonary hypertension who had previously been placed on ECMO. So their protocol was monitoring with continuous monitoring of systemic blood pressure with a central line. 16 of the patients had an indwelling PA pressure catheter, which is not all that common. But it is kind of the gold standard for measuring PA pressures, which is good. And their intention was to wean by 1 part per million every 30 minutes and increase FiO2 by 20% until they came to 2 parts per million, in which the medication was given per NG. And then they were measured at their PA pressure was measured at 1 hour before discontinuation, as well as an ABG to measure saturations as well. And so it was 1 hour before, 1 hour after stopping, and 4 hours after stopping. And so what they considered a rebound effect was any increase in PA pressure above 20%. And so that would signal a need to recommence nitric oxide. And then also changes in systemic blood pressure. So patients who didn't have the PA catheters, those were measured with echocardiogram, and changes in oxygenation or systolic PA pressures with ECMO. And then they're also measuring simultaneous central venous pressure. And so any of those changes would also kind of signal them to restart nitric oxide. So for the results, the statistics that they used were the paired t-test, Wilcoxon rank sum test, and a one-way analysis of variance when needed, comparing more than one variable. So of all the patients who had sildenafil, none of them had any rebound. So that's good. And then of the placebo, 10 of 14 patients, so 71% of those patients failed to wean with rebound. So had a measured elevation of PA pressure of 20% or more, which was a significant with a p-value of less than 0.001. And so within the sildenafil group, the PA pressure at initial measurement was 35 millimeters mercury. And then throughout the weaning process, the range was between 33 and 35.8. And so the pressure change was always under 20%. With the placebo group, their initial pressures were 31, so slightly lower. And their greatest pressure over 1 hour withdrawal was 45 millimeters of mercury. And so at 4 hours, they would return to 36 millimeters of mercury. So that included the ones who were restarted on nitric oxide. And the largest pressure change being upwards of 125%, and the lowest being around 20%, which is statistically significant. And so they weren't entirely able to kind of quantify the oxygenation because it was limited with increased needs in the placebo group and with the reinstitution of nitric oxide. There were no significant changes with needs for ventilation. However, the ventilation time decreased for the sildenafil group after the wean. And then total ICU stay for the sildenafil group was an average of 48 hours, and the placebo group was an average of 189 hours. So in discussion, kind of referring to a single dose prevention of rebound pulmonary hypertension. This was the first study of its kind, and it was kind of well planned out and had minimal variables that kind of, I think, proved its worth. And at that time, there had not been very many studies for the sake of simply bringing these kids either off of the ventilator or improving their ability to get off of nitric oxide at baseline. And so and it was already established that there is not a long-term effect on survival. So I think it's good that they weren't intending to disprove that. Let's see, and then some of their limits or the weaknesses of the study. They mentioned that the NICU attendings had some discretion on how they would wean the nitric oxide. So there was some standardization at the beginning of it, but it took place over, I think, 2 years, enrolling people into the trial. And so there was some discretion amongst the NICU attendings. So they lost a little bit of standardization at that point. And then for my purposes, there were no neonatal patients with the average age at about 6 months for the patients. And so it wasn't a great assessment for neonatal patients. And then, let's see. And then FiO2 elevated during the wean in premature patients had to be balanced with like oxygen injury. And so that wasn't taken into account necessarily because there weren't any neonatal patients. And then they mentioned for themselves, there was no measure of endogenous nitric oxide synthase or cyclic GMP levels. So if for some reason these patients had a deficit before they started the study, then they were predisposed to have failure or rebound regardless. So especially if they're in the control group. And so me and Dr. Rao were talking that this is a little bit older of a study. So I was trying to look up some newer protocols based on the study. There weren't too many reiterations of rebound pulmonary hypertension. However, there were some studies over in kind of like East Europe where were a little more resource poor, where they were trying to mimic this study a little bit with sildenafil without nitric oxide because they don't have that available at some of their smaller hospitals for some of these patients that will have pulmonary hypertension not being post-surgical. And so they were finding better outcomes with that or using bosentan, the endothelin receptor antagonist, or glucocorticoids, or tadalafil, which is a newer PDE5 inhibitor. And so seeing that these kids will at least get over the hump of rebound kind of helps them. If they can avoid having to use nitric oxide, they can at least rely on sildenafil. And those were actually neonatal patients and around 34 weeks gestation, which is a little more of the population I was kind of looking for personally. Let's see. Was there anything else there?
What's interesting about, I don't know if I'm on, if you can hear me or not, but it's interesting about the study is that there are so many patients here that had invasive arterial line pressure monitoring, which is something you see in the congenital heart surgery world. But the surrogate for that is something that we can readily use, which is the echocardiogram version of that, which is what that TR-Jet business is. So what's interesting about this paper is that it's randomized and also it's actually really easy to reproduce in the context of what you're trying to do here. Anecdotally, we've seen a lot of this be particularly helpful in some of our patients, and the dose that they use actually is very minimal. You know, the dose is the range between 0.3 to 0.5 milligrams per kilo per dose, and for chronic, that's just for the acute period. But if you think about what we use for maintenance sildenafil in patients with chronic pulmonary hypertension, whether it's a chronic lung disease patients or a child with congenital heart disease, it's much, much higher. It's on the order of 2 to 3 times higher than what this is.
Questions?
Did y'all see anything about correlation between length of nitric oxide use and the degree of rebound pulmonary hypertension? Because just thinking about like some of our babies in the NICU that just have maybe bad PPHN and are on nitric briefly, or other kind of shorter term uses of nitric, where would it be helpful in those instances to start sildenafil, but then we commit that child to being on sildenafil more long term? Just kind of thinking through more applicable times that we may see kids on nitric in our NICU.
One of their exclusion criteria was if kids had previously failed it, and so I think that maybe that skewed it, and maybe I don't think this paper would have answered something like the long term, how long they might have been before they were on it. However, they did follow up in the discussion that these kids who did have to go back onto nitric oxide in the control group were all given sildenafil and did not have any rebound. So I don't know if necessarily that little detail kind of says like, I don't think that it would be too dependent on the time that they were on nitric oxide before their effort at sildenafil.
Yeah, and I think that the gist of that, I think, was that the amount of time they were on the nitric was probably not as important as the degree of pulmonary hypertension, just because it's very short acting, and so it tends to be as soon as you come off of it, you're off of it. And I think the whole idea was that what I got out of it was that it kind of roughens out those, or smooths out those little peaks that we get when we suddenly cut it off. And most of these patients were congenital heart disease patients, so it's not quite the same population of patients that we would give it. I mean, one thing I saw sort of glaring at cardiology point was that really didn't really go into the details of congenital heart defects per se. You know, as Dr. Reagan pointed out, there's a big difference between the kind of pulmonary hypertension that you might see with certain defects and how old they are and how long they've had it. That has a huge implication as to how bad their pulmonary hypertension is.
So Jeremiah, I think you did actually brought up a really good point about resource allocation too. And talking about those Eastern European studies. So, thinking about even in places that do have ready access to inhaled nitric, there's a lot of cost associated with that. Not just the cost of the medicine, but the cost of RTs and their time and where that can be spent in a different place versus a nurse administering medications. And so there are some hidden costs that are associated with inhaled nitric, the weaning protocols that have to take place, the duration of time, like all those sort of things. So I think you bring up a really good point about, resource allocation for this patient population too, that I wonder if if they kind of look back on it now, if they comment a little bit more on that, since 2003 we weren't as ingrained in the cost effectiveness of medicine and considering those hidden costs of things as we are right now, the so-called healthcare value that Dr. Stallworth likes to talk about.
Yeah, it's surprising that I think they're trying to find ways, especially because I think those are some older drugs for sure, especially sildenafil, that almost like maybe we're waiting for a comparison study of not even starting some of these kids on nitric oxide, maybe not the post-surgical patients, but some of the ones, maybe pneumonia or the sepsis guys, or the ones with like meconium aspirate in the neonatal areas. If we could, do we actually need it at some point if it doesn't extend survival and things like that? It's like, well, why not try and lower costs? So.
Yeah, that was kind of my question. So thank you, Scotty, for that plug. And this is my ignorance talking, but in these type of patients, is the pulmonary hypertension a static process that you can just measure? It's not dynamic. It doesn't change so that you're actually measuring and treating something that you can depend on an action to dictate a result.
That's a very good point, Dr. Stallworth. In fact, pulmonary hypertension is actually a very dynamic process. And the analogy is that depending on how severe the lungs are damaged, for example, a kid with chronic lung disease, it's the thickness of the ice that they stand on. And a kid with chronic lung disease is always on thin ice. I mean, they can be perfectly normal right then and there, but any acute respiratory infection, any kind of activation, anything that can activate their pulmonary hypertension, they can go into these death spirals of pulmonary hypertension. And these chronic lung disease kids, they live on this thin ice. And so they always have chronic pulmonary hypertension. And then when they get acute on top of chronic, that's usually when they fall through the ice and they end up in the care of Dr. Ricker and others. So for these kinds of things. But that's a very good point. It is actually a very dynamic process. And it's something that we might see, and we can actually trace it out. And some of our physical exam findings are actually very good at telling us when you can expect a patient with pulmonary hypertension to have a crisis. Things like the loud second heart sound, tachycardia, hypovolemia. There's a lot of physical exam things that happen before the S hits the fan.
So I first saw this article and was like, well, of course, giving a medicine that's going to relax the pulmonary bed is going to make it easier to come off of another medicine that relaxes the pulmonary bed. And so I wasn't really that excited about it, but as I read it, I thought they did a good job. The protocol was good. I think it's interesting, the idea that maybe I can use this drug once intrally and have more success rate of getting off the nitric. The part that I have a hard time with is it didn't go into what I care most about in like that patient population, which would be the oxygenation levels. So I feel like the kid that's going to have the pulmonary hypertension that has a hard time coming off of nitric often needs the sildenafil long term or is already on it. For me, it's more the patient that like we had one recently that was a trauma where the nitric worked, and then when we tried to wean, she needed it again. And in that case, I struggle with getting the sildenafil because the benefit of the nitric oxide when it relaxes your pulmonary bed is that it only works on spots that are getting ventilated, versus sildenafil is going to work more globally within the lungs. So I can worsen a VQ. VQ mismatch and maybe make my sats worse, even if my my pulmonary oxygen, contraction's not worse. Does that make sense?
Yeah.
So that was the patient population that I, from an ICU perspective, am a little more interested in, just because I feel like the pulmonary hypertension kids likely will be on sildenafil anyways. So I'd like to see that as a follow-up, I guess.
Yeah, they noted that the ABGs were measured as often as the PA pressures on echo, and it doesn't sound like that was, like you're saying, like the main point of standardizing that, because they were just giving increased FiO2 with each wean. And
Right.
so I think, they have to look at that a little more seriously.
But I think part of the success could also be, Dr. Ricker, is about, if you look at their protocol for weaning, it's extremely judicious.
Yeah.
You know, like 1 part per million, and that's super hard to titrate, even in the context of having the RT to titrate that 1 part per million.
All righty. All good?
All right. Any other questions for Jeremiah about this one? All right, let's go ahead and move on.
All right, our next one, a little more topical, done in 2020, echocardiographic findings of pediatric MIS-C associated COVID in ultrasound in the US. Our original interest, we're obviously trying to get a study started with our echocardiogram findings on our MIS-C patients here and following them as outpatients as well, and watching for a little more simplistic changes than the depth of this one, while also following the CHOP protocol, which they followed for diagnosis. And then also kind of characterizing how COVID is affecting our children's hearts, as we've kind of seen many studies on adults outcomes with their kind of scene of myocarditis and their mortality rates, which are a fair bit higher than the pediatric patients. And so I thought this was a really good, just kind of introduction, comparing myocarditis to Kawasaki's disease, which originally the CHOP pathway has us following a very Kawasaki's related system, when after evaluations like this and other ones through adults, it doesn't entirely follow that. So this is a 2020 Journal of American College of Cardiology out of Children's Hospital in Philadelphia. Just in their intro, there have been minimal studies on deformation parameters relative to the mainstream measurements like coronary artery abnormalities and basic echocardiographic parameters, including ejection fraction and annular velocities, along with the along with categorizing the strain. The groups hypothesized that the association of reduced systolic and diastolic function are similar to forms of myocarditis instead of associations with Kawasaki's disease. So this was a retrospectively collected data and exclusion criteria included previous cardiac disease, ARDS, previous use of ECMO, and previous chemotherapy. And so the methods were over a 2-month period. Echocardiograms were collected according to MISC protocol, as described by the CDC and WHO. The patients were tested by nasopharyngeal swab for PCR or microparticle immunoassay for IgG antibodies. Myocardial injury was defined as elevated BNP and troponins. There were no endocarditis.
Endomyocardial biopsy.
There is no biopsies.
Yeah.
I guess they're meaningless. Anyways. And so there are 2 different ultrasound methods used. The Affinity 70C was used for infection protocol with the MISC patients. And then Epic CV Standard Philips Medical Systems was used for previous Kawasaki's disease for comparison, and then controls that had been collected previously. Left ventricular ejection fraction was confirmed by over 2 expert reviews for all MISC patients, also to be a little more standardized. And then standard guidelines were used for evaluating coronary artery abnormalities according to the Kawasaki's disease guidelines. So there were total 20 healthy controls who were originally worked up for murmurs, chest pain, or syncope. And there were 20 classic Kawasaki's disease echocardiograms used for comparison, and then 28 total MISC confirmed patients. And so within those, there were 2 groups that were created, kind of like subgroups that were created for evaluation that presented originally with signs of either toxic shock-like symptoms, where they had signs of cardiovascular collapse requiring volume resuscitation or pressors. And then there was a group that had KD-like symptoms. There were then 2 sub-classifications in another group and 2 separations that were created based on suspected myocardial injury or not suspected injury. And then there were 2 more sub-classifications that were created based on preserved left ventricular function, which is measured by ejection fraction greater than 55%, or impaired ejection fraction. And then speckle tracking analysis was used to measure strain and deformation studies with tracings along ventricular borders and maintained throughout the heart cycle with adjustments for access. So the statistics used for this were continuous data plotted with median and interquartile range, differences between groups measured with Wilcoxon signed rank sum test, comparisons between 3 groups used Kruskal-Wallis test, which is followed by Steele-Dwas test for pairwise comparisons. And then they noted that diastolic parameters were not analyzed due to large differences between the ages of the groups. And then logistic regression analysis was performed for echocardiogram measurements and Spearman's rank order correlation test used for 2 variable evaluation with p-values of 0.5 or less as statistically significant. I'm sorry about that. That was a mouthful. All right, so the results. So the MISC patients were significantly older by median age at an average of 11.4 years compared to the Kawasaki's disease patients at 3 years old average. And so the MISC patients also had a larger body mass index with an average of 50%, 50% of the MISC patients were obese. And then 18% of the MISC patients were, 18% were included in the Kawasaki's like presentation with symptoms, whereas 82% were in the toxic shock grouping. 8 patients were negative for PCR, and however, they were positive for their IgG antibodies. And then they included that 25% of the patients needed either needed invasive ventilation, 7% needed positive airway pressure, and 18% needed BiPAP. All patients with suspected inflammation presented with elevated CRP, ESR, and lymphopenia, and myocarditis was suspected in 61% with elevated BNP and positive troponins. So echocardiogram findings in one case within the MISC group had coronary artery abnormality which resolved on subsequent imaging. I believe they only did a subacute follow-up for this, and so that one finding resolved within 3 to 5 days. And then, and so whereas in comparison, the Kawasaki's disease group had 20% of the patients had involvement with 2 aneurysms developing on follow-up. Within the MIS-C patients, there was 46% with mitral regurgitation compared to 50% of the Kawasaki's disease group. And then there was 32% findings of pericardial effusion, 39% pleural effusion found in the MIS-C groups. Patients with suspected myocardial injury also showed higher frequency of these previous anomalies compared to the negative myocardial injury group. So higher troponins, higher BMPs tended to have the pericardial effusions and the pleural effusions. On functional assessment, so the MIS-C patients showed both left ventricular systolic and diastolic dysfunction as compared to the normal group and the KD group. Left atrial strain and longitudinal strain of the right ventricular free wall were significant changes from the normal group. And the strongest predictors associated with myocardial injury were global longitudinal strain with an odds ratio of 1.45 with a 95% confidence interval, and global circumferential strain, which was 1.39 odds ratio, and the RVFWS, or the right ventricular free wall longitudinal strain, was 1.59 odds ratio. And so compared to the normal group, the preserved left ventricular ejection fraction of the MIS-C had significantly lower global longitudinal strain and global circumferential strain, and showed diastolic dysfunction. And so within the 3 to 5 day follow-up, most MIS-C patients returned to normal ejection fraction, but retained that lower longitudinal strain and retained diastolic dysfunction. And we were talking, it's kind of reminiscent of what you see on like a T-wave inversion, or a T-wave inversion related to myocardial injury. And then there was right ventricular systolic function that remained impaired with the MIS-C group, and all strain studies had significant correlation with both the BMP and the troponin values. There's a correlate on the logistic regression. So in discussion, the MIS-C tends to follow more of a myocarditis trajectory compared to the Kawasaki's disease group, when there was a lot of evaluation for coronary artery aneurysm, which did not end up kind of carrying over. And then some of the studies in Europe did suggest possible coronary artery involvement, and they had higher, they set a higher Z-score, which might have created a little bit of bias and kind of set us down the CHOP pathway to start things like IVIG, steroids, and aspirin for these patients. And so it might have skewed it a little bit in those original findings. And then the fact that there were no discrete aneurysms on quick follow-up for these patients. And then there was no long-term follow-up as well for these patients so far that's been published. So then echocardiogram evaluation of ejection fraction and strain patterns largely suggested an inflammatory effect on myocardium and cardiac functions, with the left atrial strain proving the strongest index associated with diastolic dysfunction and myocardial injury. There, 85% of the MIS-C patients had cardiogenic shock as compared to the children with KD and as well as left ventricular dysfunction. So they did a lot of comparisons in the discussion with the adult studies that have linked a lot of the changes in left atrial strain with atrioventricular coupling. And in the adult studies, there's estimated 40% myocardial damage related to COVID deaths, so on postmortem diagnostics. And those papers were showing up to 53% of MIS-C patients also having myocarditis as it's diagnosed with BNP and troponins. So, so all in all, they're just based off of the deformation studies on previous myocarditis patients, they're just kind of driving home that point that maybe we shouldn't be necessarily treating these as Kawasaki disease. And then hopefully as they go, we'll maybe start to see the 1/3 rule for myocarditis.
The 1/3 get better, 1/3 of myocarditis get better, 1/3 stay the same, and 1/3 end up with heart transplant.
And so I think that that's probably going to take a little more time to prove that this effect of COVID. And then something that might have came for it is possibly using that left atrial strain as its own deformation study for these kids with confirmed MIS-C for monitoring if we're suspect that they're going to continue to have diastolic dysfunction, kind of how they do with the adults. So the limits in the study, the practicality of doing strain measurements, I didn't know that you do have to do a fair amount of prep to get these done, and it has to be kind of built into the system. And so I don't know how feasible it is for long-term monitoring of myocardial function. And then the age disparity between the Kawasaki's disease patients and the MIS-C patients was fairly different, with 11-year-old average versus 3 years old. And then let's see, they did collect a lot of data points. I feel like needed to be divvied out. I felt like there were a lot of tables that I don't even know if some of them were even talked about in some ways.
They're a lot of them were redundant about how the strain is categorized. Basically, so sort of the gestalt of sort of how I lumped a strain assessment is how hard is it for the ventricle to relax? Because that's what diastolic dysfunction is. So if it's very difficult for the ventricle to relax because of myocardial injury, then that means it affects your filling, it affects your coronary perfusion pressure, and all the other hemodynamics. And so where are you at risk for sudden cardiac death of these patients, or cardiac dysfunction of these patients?
And I think Colin is doing kind of the follow-up for the athletic follow-up, but I know that would be something we're keeping an eye on for like sudden death occurrences in our MIS-C patients in long-term follow-up. So I hope maybe these guys are doing their long-term follow-up as well. Just correlate it. Questions?
So I think along the short of this article is that it's a very different disease process than Kawasaki. That initially we had seen that it was sort of a systemic inflammatory response, but it appears to be much more myocarditis focused. And so the way we would do the myocarditis are patients like, they get a cardiac MR, then they get exercise restricted for 6 months, they get pulled out of sports for 6 months, and then they get a repeat cardiac MR looking for fibrosis and any kind of etiology for sudden cardiac death. And I think that's sort of the gestalt of this, rather than a Kawasaki disease-based approach. And Kawasaki's been around for, as you described, in the late 1960s. So that approach has been kind of gone through this whole process. We've only known about MIS-C for it's been about exactly 1 year since the first U.S. reported death of COVID.
So, Shri, you kind of answered that's what I was going to say. What's going to be the recommendation here relative to you have a patient who has COVID? You're going to get an echo on all those patients, but not a cardiac MRI necessarily, unless indicated, because you have evidence of an abnormal echo. And then when they're through with it across the board, are you going to repeat the echo or an MR? I mean, what is going to be the standard, do you think, that's going to allow you to feel comfortable that patients are now disease-free? That's not the right word, but don't have.
Dr. Stallworth, do you mean COVID in general or MIS-C? Because I think that's an important differentiation in the
correct
article that we're talking about.
That's right. No, I was moving toward the patients who are sicker with COVID. So borderline the MIS-C. Routine COVID, but you can answer that. Should they get a baseline echocardiogram?
That's certainly not in the recommendations for run-of-the-mill COVID.
Right. But once they get sicker and have evidence of either, the inflammatory
Cardiovascular
disease or kind of really sick, those patients, that's really what I was referring to.
And I think you're right, Dr. Stallworth, is that this is going to go along the sort of the general pathway, what we do for the viral myocarditis patients, where we do the, especially for the kids that are athletic, that are doing junior varsity level sports. I think there'll be that pathway will be very similar about exercise restriction and not letting do competitive sports, maybe even dialing back what sports they can do, because that's also based on certain cardiac load that those sports require. And so exercise restriction for 6 months has been what we've done for the patients with suspected and confirmed viral myocarditis.
So there's not going to be maybe an objective test at 6 months. Let's just say you did some cardiac MRI that would then say, if that looked good, okay, we're going to let you go, or is the deal sealed forever?
An exercise stress test and a cardiac MR is what we've been doing for patients that have significant viral myocarditis.
Okay. And then if they look good at 6 months, you kind of allow them back to business.
Yeah.
Okay.
Is this
So,
similar to what
go
we're
ahead.
seeing here? Like the only one I took care of had the reduced ejection fraction. So I haven't seen a lot of the systolic dysfunction per se, but I was just curious if it's monitoring, like mirroring what we're seeing with our echoes on these patients.
I'm sorry, what was that, Dr. Ricker? I missed the first part of your question.
Is this similar to what we're seeing here? Like, I feel like the only one I've taken care of had the systolic dysfunction.
Uh-huh.
But I
Yeah,
haven't-
what we've seen is, like, we'll see that when they first come in distress, with this MIS-C, we're seeing mostly the lab markers for cardiac stress, with the BNPs and the troponins and the being elevated. As far as primary cardiac dysfunction or systolic dysfunction, that has been fortunately quite rare. And so we haven't really seen that, but again, so the diastolic component of this is what we have not been measuring reliably. And so that's something that's hard to reproduce. And CHOP has sort of the cutting edge of this kind of strain patterns in pediatrics that's sort of left over for coming down through the adult world. So we have not done strain as a routine thing, but I think that's something we're talking about as well to follow these kids.
Yeah, that
And
left.
Dr. Ricker, I've had a few that had LV dysfunction at the time of diagnosis that have all recovered their systolic function. Like Dr. Rao said, we don't really measure diastolic function well, but the two that I follow had pretty significant systolic dysfunction at the time of diagnosis, but both have recovered their function.
Yeah, but just based on this, like the most correlative is the left atrial strain, which it sounds like they do that a lot in adults.
Yeah.
So
Interesting. A lot of times, what I've noticed is that when I'm evaluating these patients and I kind of look at like how much fluid resuscitation that they require to by the time we get to the echo, a lot of times, sometimes we'll see sometimes we'll see a ejection fraction that's lower, maybe an LV that's a bit dilated, because the patient may have received, a liter or two of resuscitative fluids, and now the patient's actually living further to the right of the Starling curve, and they may be just a little fluid overloaded. Sometimes that happens, and so, with MIS-C, we're going to presume that it's MIS-C and it's going to be a cardiac dysfunction. But oftentimes, even before the age of MIS-C, before a year ago, ancient times, we would actually sometimes see kids who came in very, very dry, have lots of fluid resuscitation, do their echo, and they actually have a slightly dysfunctional cardiac systolic ejection fraction because of their volume that they receive. It's all about preload.
It goes along with the other stuff they were finding in the article, right? Like the pericardial effusion and.
Yeah, exactly. Yeah, that's exactly right. Yeah, third spacing. Yeah.
So to me, a couple of interesting things about this article are, first off, that like you can get something like this out that quickly. Because I mean, the timing of getting this number of patients enrolled and getting all these studies done and comparison and everything. I mean, in the realm of academic medicine. It was actually a pretty quick turnaround to get this done. And I think that, right now we're seeing a lot of just descriptive articles about COVID, but this starts that panacea of all the things that are going to come out afterwards about COVID and MIS-C and following them out and seeing what happens to them, because we have no idea, I think, Stallworth, where this is going to go. We might think we have an idea of what we're going to do diagnostically to follow these kids out, but I don't get the sense that even the recognition until the past 3 months in pediatric patients has been as great as it is now, that now we have an earlier recognition of these kids, and the fact that they're presenting in a lot of different ways, that at least our antenna are now up for MIS-C. So I imagine a lot more data is going to come out. I struggle a little bit with pulling too much out of 20 patients. I know we don't have a ton of MIS-C data out there, but it's a good starting place. And I think Dr. Rao and Jeremiah, you guys do a great job of, and this article does a good job of really separating them out away from Kawasaki's. While they might have some similar laboratory findings and clinical presentations, like the disease process from a cardiac standpoint is definitely different. And you can see that just from 20 patients. I think it's, to me, at least anecdotally, it's very interesting to see the obesity thing. That was something that was really striking, because I feel like not for all of our patients, but for a decent number of them that we've seen with MIS-C, they have been obese patients. And that leads me to wonder if this inflammatory cascade, if they're not somehow predisposed to having more significant cardiac issues related to it, or myocardial dysfunction or whatever, just from their underlying obesity and longstanding problems that can sometimes cause. So the other ones that, again, anecdotally, I know of that we've had struggles with have had other underlying conditions, whether it's nephrotic syndrome or other things going on with them. So it certainly seems like that people that maybe are more predisposed to pro-inflammatory problems are going to struggle with it more than not. But again, I think that's this kind of stuff that's going to bear out more than anything else. But this is a great article of how to put together a quick research, get some information out to people to start asking more questions. I think they did a really good job.
Yeah, and also in the same vein of let's separate this from Kawasaki's disease. Let's separate the medication that we're giving these kids kind of in inflammatory states. There are so many kids that don't receive IVIG in pro-inflammatory states, but we give it to Kawasaki disease, proven to reduce aneurysms. So if we're not producing aneurysms, can we save the hospital money by not giving these kids IVIG or aspirin if they're not at risk? So I'm hoping that's kind of also something we start to build a different pathway on as well.
And even after 50 years, no one really knows what causes Kawasaki either. So, and that's the interesting part of it.
Yeah. And it seems obesity would give you cardiac strain, seems to me.
All right. Anything else on this one? I just have one last little part of our learning. So I just saw it was noted here for the odds ratio. And so I'll just give a quick little excerpt on that. So odds ratio is used to build an association, the strength of association between an exposure and the outcome, and it uses ratios, whereas it's usually compared to relative risk, which uses percentages. And so typically the calculation after those ratios, you compare it to number 1. So anything being greater than 1 suggests a link. However, it does not suggest a causal relationship between them. Anything equal to 1 can be a random finding, and there is not necessarily a finding, and you probably have to continue other investigations. And then less than 1 has a negative correlation. It might, the odds, whether it's a disease or an exposure, would be either protective or kind of suggesting away from the disease. And so it is more often odds ratios used for rare instances, rare diseases or associations or exposures, those people who had silica, things like that. And typically the relative risk is more often used with more appropriate, kind of like kind of appropriate numbers related to the actual risk, because the odds ratio tends to overestimate correlation. It's more kind of like a broad number instead of a more focused number compared to relative risk. and neither establish that causal relationship. And so I know sometimes it's easier to see these when they're brought up. And so you always kind of want to build your little Punnett square. And so I had this little one just quick and easy, right? Wait a second. Yeah, I knew Dr. Ricker was going to laugh at this one. All right, and so this little guy right here. So just the exposure, the healthy group, disease group versus the exposed group and not exposed group. This does not have the total exposed, total disease, total not exposed, and total healthy. And so what the odds ratio does is when you don't have, so I think, where is it here? When you don't have the total amount of people that would be exposed, so doing retrospective studies like this one, you want to use an odds ratio because you don't know who is exposed. So you can't actually have an accurate relative risk because you didn't know beforehand who would get it. So when you have the prospective trials, like in the sildenafil trial, you could use a relative risk much more accurately. You know who would be exposed to sildenafil, things like that. So the odds ratio is to kind of make up for that. It is more of a blunt instrument, but it helps you just establish a little bit of association. And so the better thing about relative risk is that it uses the total number of exposed, whereas the odds ratio only uses exposed versus healthy. So in my mind, just to make sense of this a little bit, I like to think of going to a casino. So generally, most people should know the risk of going to a casino. So you can easily compare yourself to many other people as a risk of going to a casino. So you prospectively, you know that it's going to be bad probably to go to a casino. However, once you're in the casino, you don't know who is actually exposed to losing money or gaining money. You only know your individual risk. So you play the odds against the blackjack dealer, which is the best odds, by the way. If you're going to go gamble, 50%. But anyways, so you're going to want to play the odds as an individual once you're in the casino. So you can't necessarily measure who else is doing well, but for yourself, you play the odds, if that kind of makes sense. So, so in retrospective studies, case control studies is where you tend to use odds ratios, whereas if you know your population better for exposure or for disease, you're going to use relative risk. Let's hear it, Dr. Ricker. I can already see it. Yep, here it comes.
No, you did excellent, actually. Odds is really hard. Odds ratio will be on your boards. And it's really hard because we think in terms of risk. So we think, just going along with the casino, we think of odds being risk and probability. So what is the probability at a deck of cards that I'm going to draw an ace of diamonds? So it's 1 out of 52. Whereas odds is more saying, I don't know what my total probability would have been. So it's more of what's the chance that I draw that card out of the chances that it could not happen.
Yeah.
So instead of 1 over 52, it's 1 over 51. And like you were saying, in more rare cases, that becomes more significant how the difference between those two numbers are. So instead of just drawing an ace of spade, which is more, I said this backwards, the ace of spades is more rare than drawing a spade in general. So my likelihood becomes more close between the risk and the.
Yeah, and it said as you get more rare diseases, like rare genetic diseases, is where you can start to say that relative risk is actually the same as the odds.
Right. Yeah.
So it's more applicable.
So that'll be the trick, is in your head, you're going to think odds is probability, and it's not exactly equal. Risk is probability, but odds is more a personal probability in a way.
Yeah.
And then the other thing that you brought up too is that the odds ratio is used a lot in case control studies. So if I'm saying I have a population that is exposed to cigarette smoke and developed cancer versus those who are not that develop cancer, but I still don't know what my other risk of other people is, that's where you're using your odds ratio.
Yeah, and it's kind of hard finding the language to describe statistics. So many people know this differently.
Well, and one of the things that you have to understand all of it to understand one of it.
Yeah.
That's why the more you play with it and apply it in these situations, the easier it'll make sense. But if you just kind of start with that concept that odds is not probability,
Yeah.
it's statistically speaking.
And the only other thing to add to that is don't forget about adjusted odds ratios too. Just to throw a little bit of a wrench into it, that adjusted odds ratios take into account other variables. So if there are multiple variables that can interplay with what you're trying to measure, sometimes you'll see an adjusted odds ratio that tries to take into account those independent variables and see if that doesn't adjust what the odds truly are, because there might be more things at play. So. Like if you have a dealer that's cheating, that would.
It's an electronic dealer. Yeah.
Email out a website that actually explains this pretty well, and then a couple practice questions, so it'll drive it home for y'all.
Oh, perfect. Yeah, there was a good description on NCBI where it just compared the obviously the risk of getting like a ligation versus sclerotherapy for esophageal varices, and then how the odds actually changed, but the risk actually stayed very stable, ligation compared to sclerotherapy. The risk is still there. It's a little bit better for ligation, but the odds would shift each time you changed one of your parameters. And so it just tells you how it's a little more blunt of a measurement compared to relative risk. And I think that those they play into each other a lot more. But yeah. Any other questions? Dr. Rao has a warm supper waiting for him. I don't want to keep him any longer.
Well, I'm on call, so.
So he's up all night if you guys got calls on cardiac patients.
Page me. Don't call me on my cell phone. I'm not
Page me.
your generation where I'm not attached to my cell phone. I'm attached to my old pager. Thanks, everybody. Have a great night.
All right. Great job, Jeremiah.
Good job.
Thanks. All right. That's it. Signing off.
Good.
Good night, guys.